Hey, I'm Dr. Frank Johnson at Sports Medicine Ultrasound, and I'm happy that you're here for the PRP for the knee, a 1 hour deep dive. I'm starting out re-recording the beginning of this webinar because we had a problem with recording, and we'll pick up about 6 or 7 minutes into the webinar with the rest of the Zoom call. Let's get started. Hey there, Dr. Frank Johnson from Sports Medicine Ultrasound. Glad you're here for the PRP for the knee, a deep dive in 1 hour. So it's a hot July day here in Alberta finally, and it reminds me of an early day when we ran this course in, I think it was September 2021, with some great friends who are our tutors, and lots of people that have stuck with us over the years for more and more training. So it's been a lot of fun, and this was one of our first. I think it was our first course in Ontario. It was great, and we run courses in Ottawa. This one's in Calgary. This one's back in Ottawa. Calgary, of course, with the bobsled. This was Calgary, Hamilton, Ottawa, Calgary. Anyway, so of course, we've had a great time. We've been able to meet a ton of amazing people over the years, and we've really enjoyed it. I'm glad you're here for some learning where we can have some fun and maybe learn some stuff. Now, just remember that you can watch somebody talk about this stuff. You can watch somebody present on it. And then you get into your clinic and you're like, am I doing this right? So the best way to actually make sure you're doing it right is to have, come into the clinic with me at Group 23 in Calgary or one of the other Group 23 doctors and learn how to do this stuff, over 2 or 3 days. But that's not practical for everybody because you're not going to fly to Calgary and get like 20 PRPs in a day. So what we've done here is I've made a PRP injection video library. So I've recorded all these different PRPs and prolotherapies in my clinic in Calgary or in Cochrane, Alberta, where I live. And I invite you to come into the clinic with me because not only do you get to be there and see what it's like, but I zoom in on my hand movements and I draw on the ultrasound screen what the anatomy is. What are we actually looking at? So this is the best way I can help you learn how to do these injections properly and safely. So there it is. It's $89 for 30 plus. I think it's like 34 live injection demos. Most of them are PRP. There's a couple prolotherapy. So let's get into PRP for the knee. Let's look at knee osteoarthritis. And then in part 2, we're going to do patellar tendon. And in part 3, we're going to do quads tendon. So this is the paper with the best drawings that I've ever seen for what exactly is platelet-rich plasma when you look at a blood column in a test tube. So over here on the left, we have the blood sample. We have a buffy coat sample where all the platelets and all the white blood cells are smashed in the middle here, just above the red blood cells. And then this is a plasma-based system where the platelets are sort of a bit more evenly distributed around the top. So what do we need to know? Well, we know a buffy coat system slams everything together. The buffy coat looks like this. It's sort of you could call it buffy. I don't know why buffy. I probably would have called it the white layer, the white coat. Wait a minute, white coat syndrome. That's already taken in medicine. We can't use that one. So what we know is that these purple cells down here that the artist chose to make purple, if we had to go back and do this paper again, I probably would have colored them white. However, they sort of stain purple on like H&E stains, I think. So that's perhaps why they colored them purple. But these leukocytes, which are white, are heavy, but they're not as heavy as red cells. But they clump down here immediately above the red cells. And the platelets sort of mix in between them. Believe it or not, the platelets actually do make their way down here. It's not like because they're lighter, the platelets get stuck up here. No, they find their way through here, just not quite as well as some of the other cells. So if you want to make a leukocyte-rich PRP, what are we talking about? Well, what that means is we want to, leukocytes are not the main goal. Leukocytes are the accident that happens when you get as many platelets as possible. So if you want as many platelets as possible, you're going to come down to about here. Well, what are you going to get? You're going to get rich in leukocytes or a ton of leukocytes. But also, what else are you going to get? You're going to get some red cells. So in trying to get all the platelets, you pick up a ton of leukocytes and you sort of accidentally get a bunch of red cells. So you get this in addition to what you actually want is this. So a red PRP, I call a leukocyte-rich, even though leukocytes are white or purple and red blood cells are red. So we should call it an erythrocyte-rich PRP, but that's not the nomenclature that came about. So a red PRP is sort of mixed up with other cells. A plasma-based system is way less likely to be sort of affected or mixed in with leukocytes, and it winds up being yellow. It's the color of serum. It's the color of blister fluid. It's the color of urine. It's the color of cerebrospinal fluid. And there's a ton of platelets, but there's no erythrocytes. So it's yellow. And there's ways to concentrate leukocyte-poor PRP Sorry, I'm getting a little bit off topic here, but just know that leukocyte-poor PRP is a yellow PRP. So once again, leukocyte-poor is yellow, leukocyte-rich is red, but not because of leukocytes, it's because you accidentally got a bunch of red cells. So Connor, what's the evidence say about leukocyte-rich, which is red, and a bit more inflammatory because you've got erythrocytes and a lot of bacteria-fighting active immune system cells called leukocytes? What does the literature say about that compared to leukocyte-poor PRP for NEOA? So Connor sent me this paper earlier today, and this is his favorite paper. It's a study done looking at leukocyte-rich versus leukocyte-poor PRP in the treatment of NEOA done in Bologna. And what they did, it's an RCT level 1 evidence, RCT, aka level 1 evidence. They took 192 people with symptomatic knee osteoarthritis, AKL 1 to 3. They didn't include people at 4, which is severe. They did not include them. And what they did was they did 3 injections 7 days apart. They said 3 weekly injections, but 1 injection on day 0, 1 injection on day 7, 1 injection on day 14. These were divided into aliquots of 5 milliliters, which were injected, and the mean platelet concentration was 1146 and 1074, so they're about the same, and a mean leukocyte concentration, which is that versus that. That is very different. That is definitely leukocyte-rich and definitely leukocyte-poor. And then they looked at people between, at the 2-month mark, the 6-month mark, and the 12-month mark. So I guess the first question is this a good study? What did they find? Well, they found that there was no differences between the groups in absolute values or improvement of the clinical scores at intervals. So they didn't find a huge difference is the answer. But what they did find was, Connor can talk about that now, so let's bring him in. But before we do that one more time, if you imagine that everybody has, let's pick a number for easy math, 200,000 platelets per microliter. Well, this represents like a 5.55 concentration. And this represents like a 5.35 concentration. Am I getting my math okay? So, but again, the concentration isn't so important. It's just like they did that times 5 mils. So they got a platelet dose of like 5 point something billion, call it 5.4 billion. And this was like 5.6 billion. So they put a bunch of platelets in. So that's a big part. So my reality check is the scores didn't change much, but let's bring in Connor for his comments. Patients come to us wanting, some patients are realistic and want a small symptom reduction, but most patients come to us wanting a massive symptom reduction. And I always have to give patients a reality check, but also when I teach, I want to give a reality check and say, look, using the International Knee, I can't remember what this was. I filled out one for my own knee just before coming online tonight. And if you select moderate for everything on this questionnaire, you'll come out with a score of about 50. Makes sense. Halfway between 0 and 100. So what this group, when they took all these 193 knees, they improved from 45 to 60. Now, if patients are paying $700 on week 1 and $700 on week 2 and $700 on week 3, and they only get an improvement from a score of 45, which is moderate, to a score of 60, which is only slightly better than moderate, they're not going to be very satisfied. So it's our job as docs to talk about, to be mindful about money. It's also our job with docs to be mindful about what is realistic outcomes. It's also our job as docs to pick the patients where they're all in, they've tried the cortisone, they've tried the braces, they've tried the exercises, and they absolutely want to do this. Now, do I inject people with PRP who've never tried any of that? Rarely, because usually, like, I'm not keen on taking somebody's $700 or $800 if I think they're only going to get a small improvement. Now, reminder that this is the mean improvement. There are a lot of people in these groups who will have significant improvement, and a lot of people in the groups who have zero improvement. So it's our job, the wisdom we gain over the practice of medicine, is to get better and better at selecting the patients who are going to have really good outcomes versus really, really poor outcomes or disappointing outcomes. So the next paper we talked about is, Connor, what's the biggest knee osteoarthritis study out there that you know about? And this is the one you threw at my way earlier today.
Yeah, I mean, well, this just was really, when the standard of evidence for biologics was typically, prospective or cohort studies. Maybe there was randomization, maybe there's a saline control arm, but the criticism is always that we're not seeing this at scale, and we're not seeing it sufficiently dosed. And this was the first study that really tackled that at scale, providing us with longitudinal data all the way out to 60 months. And we're seeing.
Let me get to the 60-month part. So this was 302 people randomized to PRP or saline, and then they followed them. So here's the breakdown in the knee severity. The PRP group and the saline group, similar-ish numbers. They didn't include any people that were Kellgren-Lawrence 4. And their baseline, let's say, WOMAC score. Or sorry, let's look at the IKDC because we looked at that earlier. The baseline IKDC was the same, and then they followed them over 60 months. Yep. Sorry, go ahead, Connor.
Yeah, I mean, so you're seeing that longitudinal data go beyond your typical 12 months, and we're seeing it at scale. We're seeing it with a control group, and we're seeing it again. What I'm always looking at was the dose even within the realm of appropriate? Like, can we even look at these scores with the right context and say we have a winner or loser here? And all those boxes were checked. And again, this is just at this point a drop in a bucket of a very large evidence pool, as you mentioned the Centeno infographic from earlier. But I think if I was to pick one study, and this was published in 2022, so it's getting a little bit dated, but I think it's a great starting point that can say that PRP for knee OA works.
And this was done at a university in China. I didn't actually pay attention to which university. However, I don't think there's going to be any university anytime soon that exceeds a study with 640 people, right? It's just not possible. Like the money required.
I haven't seen a study that's even got more than 300 at this point.
So if anybody wants to do a deep dive into this, but again, look at the IKDC scores that they measured. Remember, the baseline was, again, if you score, like if you just say my symptoms are middle of the road in everything they ask you, you're going to get a score of 50. And these people had their baseline was like 47, and they had a maximal improvement at 6 months, which was sustained out to 12 months, sustained out to 24 months in this group. The saline group, of course, they had an improvement in symptoms from 47.1 up to 51, even just with saline. Again, the bar is that we get better improvement than saline, and I mean this is way better. Like the PRP group is way better than the saline group. Is it worth $700 3 consecutive weeks in a row? That's up to the patients. That's up to you as a doc to describe that. But at least we've got some data to say this is real. On average, these are the numbers you can get. Do I want something better for my patients? Absolutely. Like if I'm spending $2,100 on 3 consecutive weekly treatments, would I want something better? Absolutely. So that's where it comes down to us to try to select the patients that are going to do the best.
Yeah.
So what dose do I use? Well, I put in, this is my recipe book. So over on the left, if you've never seen this before, my recipe book for cortisone to take you all the way through what I think is an optimal candidate, a suboptimal candidate, what anesthetic do I use, what cortisone do I use, and what do I do post-procedure. Same thing with hyaluronic acid, same thing with Prolo, same thing with PRP. For PRP, I want to aim for 10 billion platelets. In order to do that, I got to draw a lot of blood, like sort of, I think, Connor, are you sort of recommending for the people that want to stick with the, really tight to the evidence using 80 mil draw, or are you saying 40 is enough? Like, how do the conversations go when
Yeah,
you're out in the room?
so it generally is like assuming the patient has a baseline platelet level of around 200 or so, which most of our patients are going to have. You need to draw at least 50 mLs of whole blood in order to even have enough raw materials. And then, whether you use the key system, whether you use any dual spin system, there's going to be a certain recovery percentage of platelets you're going to capture from there. And somewhere around 80% is a good ballpark. And so, in order to cover your bases, to make sure that you factor in capturing 80% of whatever's in your whole blood, knowing that you need at least 50 mLs in order to even have 10 billion there, we recommend 80 mLs as a draw to make sure that you can accommodate for maybe a slightly lower recovery if the protocol isn't perfect, maybe the patient's slightly below baseline levels. So, 60 is an absolute minimum, and then 80 being that optimal figure to know that you're consistently above 10 billion.
So I just typed into the chat there. So if assuming patient has 200,000 platelets per microliter, if you draw 80 mils, you'll get 16 billion platelets, at the beginning when you start processing. So that's how we can kind of hit that, 10 billion platelet dose, is you got to start with a lot.
Yeah, because you're going to lose some along the way. The patient may have lower platelet count at baseline. The preparation may not be perfect, right? There's variability in terms of who's doing the processing, how they're feeling that day. I mean, a million things can go wrong, right? So, shoot for a little bit more. That way you have a bit of margin.
Absolutely. Now, I'm sort of a big tent guy, and I want everybody to feel included. I want to tell you that when I started doing this, I used, a gel tube separator that only took 12 mils of blood. And my point there of saying this is I started out with small draws, and as I've gone through this process, I've gotten more and more and more blood. Okay. And I think that's a normal progression with everything in life. You learn to crawl before you learn to walk, before you learn to run. I think you start out small before you go medium and before you go big. So if you're on the call and you're doing a smaller draw and you're uncertain if it's time to move up, reach out to Connor, reach out to his team and say, look, here's what I'm doing. What sort of improvement in my outcomes do you think I'll get or could be possible if I go to a higher to drawing more blood? So I just want to throw that out there. I started small, now I go more. I just want to show you this because my full-time passion, my full-time job now essentially is teaching and video editing. And I see patients as like for fun on the side. I recorded this one to show you my technique for when I have a dry knee, meaning there isn't a clear visible fluid pocket. What do I do? So I'm just going to hit play on this and I'll skip forward to the relevant
Dr. Frank
part.
Johnson from Sports Medicine.
So here we go.
And I might be able to, but I think there's a few more steps we can do. So the next step is to ask your patient to bend their knee. Could you please bend your knee, sir? And that might be enough. So now we reassess. And there is a little bit of fluid that popped out there. Could you please bend your knee a little more? And now we've gone too far. That black curve is the articular cartilage of the distal femur. So that's too far. So what we'll do is we'll say, could you push your foot towards the end of the bed, just further away from you? As it collapses, there's just a tiny bit of fluid there. So that's probably the best view I can get. So the challenge here is as soon as I touch the patient's skin with a needle, there's going to be a contraction reflex and their foot's going to slide down. So usually what I'll do is I'll have them take off their sock so that they've got bare skin on the table. The other thing you can do is have your right arm sort of anchored, shooting like this. That's a bit more of an advanced technique. Patella on the right, femur at the bottom left, and there's sort of a V-shaped fluid pocket. But I really, really want to confirm this with some anesthetic. Now the challenge is with PRP, I don't want to be putting in too much anesthetic. So what I'm going to do is I'm going to put in a small amount of anesthetic into the skin and subcutaneous tissues, and then I'll switch to normal saline if needed. Long axis first, spin, clean off, anesthetic into the skin. So now I've just gone through the distal ITB and put in just small puffs of fluid into that vastus lateralis and lateral ITB. So that's pretty much anesthetized now. So again, the reason for the normal saline is just to add the tiniest little bit of extra fluid to confirm your location for duraling. So you can see me, I'm literally touching that pointy aspect of the femoral condyle. So from right about here, if I give a bit of a push, you'll see the fluid flow to the around the corner and sort of push away that fat pad. So that tells me I'm happy with that fluid compartment. Now I've pushed in less than a milliliter. What I'm now going to do is I'm going to drop the ultrasound probe. I'm going to use this sterile cavity wipe to hold on to the hub of the needle, and I'm going to put on the PRP, and I'll explain why.
So the reason I did this video recently was because in our courses we teach how to do this in cadaver lab, because I would say that 40% of the knees I inject PRP or hyaluronic acid look like this. And I do not want to default to going back to the blind technique in the front of the knee, just hoping I'm in the right spot. I think using this technique is tried and true. It takes practice. It takes practice, but this is an undeniable way to get it into the right spot. Now with the safety here, what I'm doing, because a lot of docs will leave the needle in place. I want to be clear here. I'm using sterile gloves and I'm using a cavity wipe, which is a disinfected towel, to hold onto the hub of the needle, because I don't want anything bad coming from my gloves. I don't want to be talking during this procedure. I should have had a mask on, but hey, I'm far from perfect. And then I dial in. The other nice thing about this cavity wipe is it gives a good sort of a high coefficient of friction for you to grab onto the hub, because otherwise when your gloves get a bit slippy, it can be difficult. So we'll go back to the video here.
Is at the lateral aspect. The PRP is yet another watery product that I could use to push away that fat pad. I will now go into long axis and show you what it looks like as I'm filling that up. And you can see I'm adding more fluid just superficial to that cartilage. And now go back to short axis. And so there's the PRP in. And so now I've got a much more obvious target for my my duraling. It looks like the target's like even doubled or tripled in size. So now what I'm going to do is I'm actually, just for simplicity or technically, to make it more technically simple, I'm going to get a completely different Duralane needle.
So I just wanted to show you that. Just a reminder again that this is my passion. I think the best way to learn this is in a live course in Cadaver Lab. But then when you get back home, you still need somebody to hold your hand. So there's that product. Dr. Sacco said, what role does PRP play in the management of degenerative meniscus tears? And I know my answer, but I always like to say, okay, what do other people know about it? So I Googled it, and what did I find? I found a reasonably good paper from 2019 done by orthopedic surgeons in Poland. And now the hard part with papers is, in my mind, if you see one paper that shows an optimistic outcome, it's a great starting point, but it's far from comprehensive evidence that is universally reproducible with every one of us on this call. So what they did is they essentially said, hey, you got a certain meniscus tear, just slam the hell out of it, just like you would do a needle tenotomy on a common extensor tendon. Just do that for your meniscus tear, and if it doesn't go great, we'll take them to surgery. I don't know if this orthopedic surgeons in my area would be super keen with that, but I love this. It's a cool paper. It's possibly the future, or not. Who knows? We'll find out. Now, what they did was, again, the paper wasn't super clear on the extent of the meniscus tear, the size of the meniscus tear, the grading of the meniscus tear, the symptoms of the patient. But what they did was they looked at MRI healing of the tissue, and they looked at also when they went in to actually look at arthroscopy, when they did arthroscopy on these patients because of ongoing symptoms, what did the meniscus look like? And they said that just needling people, the meniscus failed to heal well by MR findings and arthroscopy findings in 70% of people, and it failed to heal well in 48% of the PRP augmented people. So again, these were people that had the needling. These were people that had the needling with PRP added, and these were people that just had the needling. So the point here is, does PRP heal meniscus tears? No, but can you get some healing in certain circumstances with some subgroups of meniscus tears? Yeah, and that's what this paper proved. So I thought it was a cool paper. So what they saw was, and again, the numbers were pretty good for a surgical group. So up here is the MRI group, and then here is the surgical assessment group. So like any paper, it's hard to really understand the numbers without, going through exactly the paper on your own. That's why I put up here this pub ID and 3510357 if you guys want to look at that one. So, but I certainly would not be doing this starting tomorrow in your group. What this graph showed was that at 50 weeks, how many of the needling alone people managed to avoid having an arthroscopy, and at 50 weeks, how many people in the PRP group with the needling managed to avoid arthroscopy. And they followed them out kind of like 3 years. And so I thought it was a cool study. They said, hey, the PRP seems to add more to the needling than just the needling alone. So I thought it was neat. My reality check was this. Oh, wait a minute. That was, sorry, forget that. That was something else. One of the docs out there who's on the call, I saw you out there on the call. Thanks for sending this in. They're increasing this was a doc from Japan, actually. They're increasing reports that platelet count may influence clinical outcomes in your practice. How does patient age affect PRP response, and do you modify the formulation, dose, or sequencing for older patients? I think we sort of roughly know older patients need more of everything. They need more statins. They need more cardiac bypass surgery. They need more physio. Same thing. They need more platelets. Another doc asked a question. Sorry, I got my slides a little bit out of order here. Another doc asked a question about growth hormone protocols. So the best commentary I could find on this was from Centeno. Remember that Centeno PRP RCT thing I asked you to look at earlier? Centeno is a physiatrist based in Colorado who built a huge regenerative medicine franchise. And he was really good at putting out a bunch of blogs. He doesn't put out as many as he used to. But essentially it's like, there's not many papers in humans. There's lots in animals. But this study that he looked at in this 2019 blog looked at HGA plus PRP group did better for the first month. But then by the second month, there was no difference to the groups. Now, Connor, I want to ask you, because I know one of the docs that you work closely with, feel free to talk about him if you wish. Otherwise, just keep it under your hat. Uses this in certain cases.
Yeah, to be honest, I don't think it's a mainstay in what they use as far as combining it with PRP with any regularity, because as Chris has kind of alluded to, and as the data set kind of suggests, it's fairly inconclusive as to whether or not it's kind of a standard of care. But it's certainly something out there that people are experimenting with, and I think as that continues, you'll see the data set grow, and it may be something worth considering in the future, depending on, of course, how this is all regulated moving forward.
Absolutely. So that was Dr. J.A. who asked about the growth hormone. Here's about the PRP and aging people. So sorry, I got those out of order. So just a quick rundown is we don't know that much about platelets as they age. Sorry, let me take that back. I don't know much about platelets as they age. Connor probably doesn't know as much as he'd like to. I don't think any of us know as much as we used to. But last time I dug into this for a presentation, many of the papers said, but there is conflicting data in the hematology literature. So essentially, here's a paper you can look at if you're really curious. Screenshot this. I don't know the PubMed ID on this one. My apologies. You can go back and watch the recording of this video later if you want to get this, the name of this. But it can help you kind of understand a bit more about some of the physiology of aging platelets. Not only like in their life cycle in the sort of 7 to 10 days, but also platelets as humans age. And then here's another paper from St. Bart's in London, St. Bart's Hospital at Queen Mary. And again, this is an immunobiology paper published in essentially hematology journal. And if they have conflicting evidence and they don't know the science is settled, then certainly I think we in the regenerative sports medicine field have I don't think we have a much of a leg to stand on saying that we know the answer. But it's really interesting, and hopefully as time goes on, we'll understand more. There is conflicting literature on whether platelet size and platelet activity changes with age. All right. Okay. Dr. Amin,
Frank,
sorry.
just to chime in with a really important note. So it's not only just how do the platelets change as you age, and I feel like we're plugging Chris a lot in this, but I do think there's one other article and one lab study that he did that actually looked at how older cells in the body respond to platelets and respond to the growth factors within. And what they actually found was that as cells age, as we age, their responsiveness to higher concentrations of platelets increases. And so what he basically found was that for patients under the age of 50, if we went up to 14, 20, or even all the way up to 30 times concentration, you're kind of seeing an asymptote in terms of how those cells respond. With cells from patients that were above 50 years old, they continued to see almost a linear effect as the concentration increased. And so it's not just the platelets themselves and how that influences, how aging influences that, but just the cells in your body and how they respond to growth factors and kind of the ability for them to respond to higher concentration. So I'll post the link in the chat here. Really worth everybody taking a look at. This is just a lab study, right? We don't know how this scales in humans, but I think it's an interesting, it's kind of an interesting thought exercise.
And shout out to Connor for using the word of the day, asymptote. That was impressive, man.
Got a couple of those in my back pocket when I need to, when the camera's rolling.
So Dr. Min said, what's a platelet dose for patellar tendinopathy and tear? And again, this goes back to, well, it depends what the the symptom or what the grading of it is, because we know that for knee arthritis, there's Kellgren-Lawrence 1 through 4, and then the MRIs can break it down even more. And we don't have a good grading system for patellar tendinopathy versus tear, small tears versus big tears. Obviously, for a big tear, the platelet dose is 0. Don't do it. For minimal patellar tendinopathy, the dose is 0. I wouldn't do it. However, for everything that sorts of bunches towards the middle, what can we rely on? We rely on finding stuff on the internet. And this was a good paper from years ago, from a few years ago, I meant to say, that was headlined by a guy named Peter Everts, who is the chief scientific officer at a large PRP company in the States, Gulf Coast Biologics. He's since moved on to become a consultant for another company. And then some other big hitters in the field, they all sort of got together and said, hey, let's just sort of agree. Let's have some meetings and agree on sort of some dosing. What they found was that they looked at all these different papers. They must have selected them very carefully. And they said, look, below 3 billion platelet dose, all these papers showed very poor outcomes for PRP. Above 3 billion platelet dose, these papers showed good outcomes for PRP. And these papers were over a broad range of things. What sort of things? They were a broad range of rotator cuff tendinopathy. When this group looked at this a few years ago, they couldn't come up with they couldn't come up with a clearly effective PRP dose based on the papers they reviewed. When PRP was used to augment rotator cuff repair, they said 3 to 5 billion. When they said common extensor tendinopathy, 5 billion. 4.5 billion. Ulnar collateral ligament, 4 billion. Knee osteoarthritis, 5 billion. Another paper said 10 billion, and patellar tendon, 5 billion. Now the hard part is to get 5 billion platelets into patellar tendon. Like I can put a lot of milliliters, a high number of milliliters into a knee joint. I can put a large number of milliliters of fluid into a glenohumeral joint. I cannot put a high number of milliliters of fluid into a patellar tendon. So it's hard to achieve this dose, like exceedingly hard. And the only way it can be achieved is with incredibly high concentrations. So what do I do for patellar tendon? I say, look, I want to draw a minimum of 40 mils blood, 50 mils of blood, and I'm going to concentrate it down to probably 3 milliliters of injectate. When I came up with this sort of recipe book a few years ago, was to aim for about 2.5 billion platelets. That's a little ways off. That's a little ways off the numbers we just saw here, but it's not light years away from it. So it's good to know that I wasn't too far off what that paper looked at. I want you to know that a common amount to inject in a patellar tendon is about 2 milliliters. It is pretty uncommon that I'll exceed that. However, in a big, floppy, gross, yucky patellar tendon, maybe I'll do up to 4, okay? And then I'll follow up with a Victoria Institute for Sport assessment, Victoria Institute for Sport Australia patellar tendon questionnaire. So this is how you get your data, is use validated patient-reported outcome measures. So this was a dude who, you see he's got a little scar there. He actually had a non-related distal femur benign tumor excised, but then when he was recovering from that, it gave him some downtime to have a patellar, a really stubborn, this is like an 18-year-old kid, really stubborn, really yucky patellar tendons.
Hey there, Dr.
That
Frank
were
Johnson
giving him
from
some trouble. It gave him some downtime to get these injected. I'm going to go into short axis so you can see kind of how yucky. Well, so in long axis, you can see there like some really, really gross stuff. It looks like there's a tear there. I don't think there is. And the reason I don't think there is just ultrasound physics. And when you're in the room monkeying with the probe, you can kind of get some insight that just a single static image doesn't give you. When I go into short axis, you can see that there is these really dark hypoechoic areas. So the way I injected this young man who is taking this like an absolute champ, I've injected a lot of patellar tendons, and this guy was probably the best patient I've ever had at this. So the technique is as follows, just sort of repeated trephination. I'm using I will see what needle I'm using shortly. I couldn't tell if it was an orange one or a black one or a green one. But so what I do is I want to make it clear. I want you to inject the yucky areas that look yucky on ultrasound, but I also want you to inject the healthy areas. Lots of times I'll stick my needle in the yuckiest part and the patient says, no, doc, that's not the spot. That's not where the pain's coming from. And I'll move my needle around to an area that looks good, and they'll hit the roof. They'll say, oh, that's the spot. So it's almost like there's some parts of a yucky tendon.
The good news is, it was really fighting. Sometimes I put a needle into the tendon, that push the fluid in, it just opens up.
So there's sometimes it's almost like there's some tendons that become so yucky they become insensate. There's some areas that become insensate. And what I was telling him was that I had all this fluid and I was trying to push it in and the tendon was fighting back, which is a great sign. So I don't think I got all the fluid in him. But anyway, so again, this video is part of this 30 injection video library of PRP. It's available. It's in the link is in the chat if you want to check it out. Quadriceps tendon. So to answer your question there, Dr. Amin, 5 billion, minimum 2.5 billion, and just keep hitting them over and over again. How much tenotomy would I do? I'd probably do like 20 mils. Now, quadriceps tendon. The only quadriceps tendon video I had was in a guy who actually had a super duper high grade. I'll turn down the volume on this and we'll hit play.
Hi there, Dr. Frank Johnson from Sports Medicine Ultrasound, here to show you a quadriceps tendon.
This was a yucky one. So this gentleman was golfing. he felt a tearing sensation. He came in, one of our sports docs said, oh, it must have been a meniscus or something. And I went to scan him for to do a hyaluronic acid into his knee, and there was all this fluid just under the skin. And I went, what is this? So you see, he had all this fluid under the skin where his quadriceps tendon should be. And I went, uh-oh, you didn't tear your meniscus. You ruptured your quadriceps tendon. But he had enough of the quadriceps tendon that was still intact, as you see here, that he had a normal straight leg raise. He could walk stairs just with a little bit of difficulty. But he had this was a big tear. He went to see the surgeon. The surgeon said, I don't know if I can get you any better than you are right now. Why don't you try PRP? See if we can help your symptoms. And if you're still struggling with weakness, I can always come back and do a secondary repair later. So, so Dr. Amin, what would the platelet dose be for this guy? Oof, like we're not going to grow back anything. I know you know that. But for anybody on the call who's new to this, PRP does not regrow tissue of an injury of this magnitude. It's not possible. Connor, can you think of any sort of miracle cures you've seen out there with 20% or 30% Achilles tendon tears, or 20 or 30% rotator cuff tears that have really convincingly been hey, I got this dude that was a super healer and PRP was part of it?
Well, actually, I don't know if he's on this call, but Dr. Andy Reid in Canmore is a huge advocate. I mean, from the Achilles, he's batting 1,000 when it comes to Achilles. And if he's on this call and he has had any failed cases, he's jump in the chat and let me know. But whenever I've spoken to him about it, he gets phenomenal results using PRP, and he actually himself has torn his Achilles and took a non-surgical route, and that's what he advocates for. So I think it can happen. I think it's out there. I don't know if these are exceptions to the rules or not.
Totally. So again, just for context, if this dude here came into my office and when this dude came into my office with this enormous knee, I went, man, I'm not doing PRP in your knee. And the reason I did PRP in his knee was because he went to see one of our sports medicine surgeons here in Calgary. The surgeon said, go ahead, try the PRP. It's not going to hurt anything, and I don't want to do surgery on you just yet. So that's part of my decision making. So we talked about this earlier. How am I going to get enough platelets to be of any help to this guy? I got to draw a bunch of blood. How do you get a bunch of blood, or how do you get a bunch of platelets? Remember that if super duper simple math, if you just imagine for simplicity's sake that patients have 200,000 platelets per microliter, you do that 2 times 5, and you get 10 billion there. Okay. 2 times 50, you get the 10 billion. Nice, simple, easy math. Just remember, every time you draw a 50 mil tube, you're probably starting with around 10 billion of platelets. Okay. I've got an MCL video in the library as well. I don't have a PRP video, but
Hey there, I'm Dr. Frank Johnson from Sports Medicine Ultrasound.
My technique for injecting tendons and ligaments is almost identical, whether I'm using dextrose or PRP. So for anybody on the call who's wondering if there's a difference, there's very few circumstances where I'll modify them. They're almost exactly the same. One of the things is I might use more volume and be more aggressive with the dextrose, simply because it's mixed 50-50 with lidocaine. And with PRP, I don't use lidocaine. I don't use much lidocaine. I use lidocaine when I know the patient's not going to tolerate it. And so this was a guy who had a relatively high-grade injury to his proximal MCL. He did not have gapping. He did not have profound laxity. He had a small amount of laxity. And the sort of central part of it, you see here, the tendon looks okay. There it doesn't. The sort of like the central part of his MCL had a hypoechoic defect. And he's actually got a Pellegrini steta lesion up here, which is a sign of an old MCL injury. So he must have done something when he was a lot younger. And then he's aggravated it here. And he came in to me and said, I've got this MCL thing. And I said, look, I am not very pushy with a lot of Prolo or PRP, but with MCLs, I've got in the back of my mind from a few successes that I will be much more assertive with patients and say, I really think you should do PRP, or I really think you should do Prolo. because I genuinely think it's going to help speed along your return to golf or return to sports or hockey or whatever. It's not necessary, but like you will get better without this, but I think it'll help speed it along, and then patients can decide for themselves. So what do? I inject with the probe in long axis, and I simply come out of plane, and I just pop my needle under several times, lots of different areas. I do scuff up the bone a little bit. I don't usually go for the meniscus in this situation. I just stick with MCL. And I ask patients all along the way, is this a sore spot? Is this a sore spot? Obviously, there's lidocaine in here. So very quickly, you lose that window of opportunity to ask them, is this the sore spot? However, in this case, not only am I interested in the sore spot, but I know there's actual structural integrity issue here. So even if this isn't sore, I want to hammer this as many times as I can to rough it up and make it as strong as possible, to scar it down as much as possible. So that's in the video library as well. We've got a diagnostic course. The last webinar, I said this was going to go live June 1st, I think. We've had some delays with some technical issues, but I help teach you how to go through these algorithms, and there are a bunch of knee joints. I help you learn what words to say, how to interpret these images, how to use AI charting tools to put them into formal, beautiful radiology quality reports, forgive me. I do knee joint, pes anserine, quad tendon, patellar tendon, Baker cyst, along with, another like 19 body parts. So just know that that's out there. We'll include that in the mail out when the recording's ready. And I've already got some requests for a webinar, so we'll get that to you in a webinar. And essentially, that's all the content I had. Connor, did you have anything else that you wanted to share on the group?
No, well, I think, Frank, we chatted earlier about alternatives to PRP and sort of how you counsel patients on where PRP fits into some of their options that exist out there, whether they're options you provide or not. Can you maybe just walk people through how you counsel them, and so what are some of the factors you're looking at?
Yeah, thanks for asking that. Essentially, I was kind of joking with somebody earlier today that I use, rather than algorithms, I use like a menu approach. Like if you go into a Vietnamese restaurant and you've never eaten at a Vietnamese restaurant, you don't know what the words are, and you're really glad that there's a photograph, an easy way to order, like by number, and a price tag attached to it. And so that's what I do with my patients. I say, look, here's the menu of options. They say, you're the doctor, what do you recommend? And I say, and I got this from, really good doc I work with, David Manning. He's like, I refuse to answer that question until you tell me what your goals are. Because if you tell me your goals are to never have knee pain ever again, like, we're not talking the same language. If your goal is to play golf at the family reunion next weekend, I'm probably doing cortisone. If your goal is sustained 30 to 50% improvement with a natural product, I think PRP is awesome. So refusing to answer the question about what to do until you know more about their problem is a really good way to do it. And using a simple menu-based approach, and trying to identify, do the patient's goals align best with cortisone? Do they align best with hyaluronic acid, or do they align best with Prolo or PRP? I almost never use Prolo therapy as a standalone treatment for knee arthritis. Like for around the knee, I use it exclusively for soft tissue, like ligaments and tendons. But if the patient says, I have zero money, the only way I can get anything done is if insurance covers it, I'm like, great, cortisone and hyaluronic acid. The patient says, I've got a great spending account, or, I've got some money, I want something that is extremely natural. I'm like, great, let's try PRP. So I'm super pragmatic and menu-based with the patients and helping guide them. Ultimately, they'll say, what should I do? And I say, if this were my knee, this is what I would do. And then I give them a straight answer, and then they can decide.
And just to build on that, looking forwards at other expensive biologics, we're talking about a patient comes in, they had a friend that received a protein-rich PRP, call it like an IRAP or an N-Stride product, and then also patients that are looking at more advanced cell therapies like adipose tissue, bone marrow. How do you consult patients on PRP relative to the protein-rich therapies like the N-Strides and the IRAPs, and then some of those more advanced cell therapies, whether they have to travel south to get them or otherwise?
I keep it super pragmatic. I say, look, here's what we can get done in Calgary. Here's what we can get done in Cochrane. These other things you're going to have to travel for. And then almost always that's a turning point in the conversation. And I say, look, if you want one of those other things, I can get you in touch with somebody, but it's going to involve a lot more money, a lot more travel. Okay. Now, and when it comes time to when do you bring, so all those docs on the call, when do you bring those things into your practice? I would say you bring those things into your practice when you're so bored with hyaluronic acid, Prolo, and PRP that you are dying to add something new to your practice. Because the more things you bring into your practice, the more complicated the counseling is. What do you, so that's sort of one way to answer the question. The other way to answer the question is these biologic things like protein-rich stuff, you can get more proteins in it by just adding more volume, by adding, because there's exosomes in your platelet-poor plasma. There's a lot more proteins in your platelet-poor plasma, but there's only so much volume in a tendon or in a knee. So it just becomes a lot more, the more things you have, the more difficult the decision making is. That's my approach. What approach have you seen other doctors take who are keen on pushing the limits? They're getting bored with PRP. They really want to add more stuff. What approach have you seen, Connor?
Well, I think people look for differentiation, right? As you put it. I mean, some people simply just get bored with the standard of care, and they want to kind of seek out, new innovative treatment options that address a gap, whether that's better outcomes, whether there's longer lasting outcomes, whether there's other things. Ultimately, what we typically find is that the evidence doesn't necessarily support some of these more novel therapies. And then second to that, often the cost of them doesn't you can't reconcile that with the cost of even something like PRP or even HA, right? If you're charging a patient $1,600 or $2,000 for a treatment that compares to PRP that you're pricing at $800, am I getting 120% better outcomes with this other therapy? Because if I'm not, then is it something worth sticking with? So, and that's where we just see the market continue to move back to the sort of tried and true standard of care, and as you put it so eloquently, kind of pragmatically work through some of these more novel therapeutics once the evidence base is there and once kind of the economics actually make sense.
Yeah, and thanks for sort of prompting me with that. I totally agree with you. A lot of these things are more money with not necessarily better outcome. I didn't have this in the presentation, but this is the sort of menu approach that I use. Everybody who comes to one of our courses gets this. If you, Marianne, you read my mind, Marianne. We did this at the exact same time. And actually, Marianne, one of our docs translated this into French, so we can get this for you as well. If anybody else wants a copy of this menu, type in menu into the chat, and we can include it in the mail out. Otherwise, Marianne, I'll send it to you along with the French one. So I updated this recently, like actually just yesterday, because I wanted to, number one, I wanted to increase my price of PRP I sell in the clinic. And so I wanted to print new, I've got these on 16-inch by 20-inch foam boards from Vistaprint. And the foam boards cost like $40, and I've had these for like 7 years. I'm like, okay, it's probably time to increase my prices a bit. And what I did with this one is I show it. So it's again this sort of the Asian food restaurant. And again, the reason I bring up the Vietnamese food is because we went to one of our courses. One of our docs who is Vietnamese. He took me to a Vietnamese restaurant, and I'm like, I don't recognize these dishes. He's like, don't worry, there's pictures. So I've got the pictures here. I've said, how many do you need? And 2 to 3 per year. Well, the Chinese study looked at 3 back to back to back and had some sustained improvement over 2 years. I've got other people who come back twice a year or 3 times a year for PRP. So, I had to write something in that column to make people realize that there's some variability. And for example, $8,000 for stem cells, you're going to have to get it more than once. It's not a one and done. I also put down here the joint health thing, because we know surgical replacement is not healthy for the joint. It destroys the joint and replaces it with something more robust. And we also know that cortisone isn't healthy. So the fact that there's like red check marks and green check marks, red X's and green check marks is sort of a nice, easy way to communicate to patients, what's healthy and what's not. And then, I've just put some top tips in here for you as a practitioner, or also things to counsel the patients on. So for example, maximum 4 times a year for cortisone. But, if I'm using a lower dose and the patients are waiting for a knee replacement and they're really struggling, yeah, sure, I'll do 6, sometimes more in a year in select cases where it's medically appropriate. I've got some people that need treatments for HA every 3 months. Others come once a year. Some people may need 2 treatments of PRP 6 weeks apart. Is that a random number? Yeah, it's a random number, because I don't want to bring people back 3 weeks in a row. I also don't want to tell them they definitely need a second one, because I think there's a lot of people that I may overtreat. Whereas I know there's people on the call. Thank you everybody about wanting the menu. It helps me feel like the stuff I do in my spare time is valuable to people. I think that if there's anybody on the call who's doing, you got to buy 3 or you got to buy a pack of 2, I'd be really interested in hearing your customer service management of that, because one of the issues that I hear from people that do that is there just is a little bit of fiddliness with customer service. Like the patient who pays for a package of 3 PRPs comes back after the first one, said, man, my knee blew up, I didn't want that. Or they come back after 2 and they say, my knee feels amazing, I don't want to pay for the 3rd one. So I always think there's a bit more customer service hassle than needs to be by selling a package or telling everybody they need 3. So, but that's my opinion. And the way I practice and isn't necessarily going to be the way that everybody practices. So for whatever that's worth, we'll send out when the recording's ready, the menu. I also want to send out a link to the video library, because I have poured my heart and soul into that video library, and I think that it is the next best way, apart from coming into Calgary and being in the clinic with me and my colleagues at Group 23 during an injection clinic. I think the video library is the next best thing. I think they are 100 times better than most of the videos you're going to find on YouTube. And the reason I know that is because I've looked. Almost everything on YouTube is a bit more amateurly produced. So I'm super proud of that product, of this video library that I've produced. And there was one other thing that I wanted to put up here, and I've completely lost my mind. Anyways, it is coming up to the 1 hour mark. I want to thank everybody for attending, and I hope there's been some value you got. At a very minimum, we gave you some PubMed IDs for some of Connor's favorite papers. We gave you a little bit of dosing strategies and some menus, and yeah, thanks for spending your precious summer evenings with me and MD Biologics team. And I know what I was going to show you. I think the best way to learn injections is in a course where you have one machine for every 2 doctors. And this is what we do. We bring in one machine for every 2 doctors. And for those of you who want to learn a bunch of injections, we've got a top 75 course where we teach. So if you've been doing ultrasound guided injections for years, have a look at this course where we teach 75 injections over the course of a weekend. And if you're relatively new to ultrasound, and let's say you've been doing ultrasound for a year or 2, we've got a top 25 course with a cadaver lab included. And if you are brand new to ultrasound guided injections, we've got a top 10 course. And we do that over a weekend. Cadaver lab is the most important thing. People tell us over and over and over again. But again, it's critical that you get a course where there's one machine for every 2 students, because there's a lot of courses out there that'll put 4 students around one machine, and you get almost, so you fly to LA, you fly to Miami, you fly to Kansas City, you fly to San Diego, and there's 4 of you fighting for one machine. It's a waste of your time. It's a waste of your money. Find a course somewhere, ours or somebody else's, where there's one machine for every 2 people. So that's my little plugs for what I think are the best way to learn this stuff. And thanks very much for your time. And where's my next podiatry course? That's a great question. I don't actually know, because actually I'm doing a podiatry course in Ottawa next weekend. Yeah, I don't know. We'll get that to you as well. The place to find the podiatry information, if you're curious, is sportsmedus.com, and podiatry courses and events right there. We've got another one. We've got a website called Podiatry Ultrasound with no space, podiatryultrasound.com. So there's our podiatry, our podiatry brand, if anybody's interested in that. Okay, thanks so much, everybody. I'm happy to stay on the line. If anybody wants to turn on their camera and ask a question or just put something into the chat, I'll stay on a few more minutes. But thanks so much for your time, Connor, and MD Biologics team. Thanks so much for helping arrange this. I had fun.
Yeah, thank you, Frank. Thank you, everyone, for joining. We love this community. We love having the opportunity to put these on. If anybody has any questions about how to integrate this into your practice, if there's anything that Frank didn't cover, he offers obviously a tremendous amount of knowledge and resources. Or if there's any gaps, reach out to either myself, Frank, any one of the MD Biologics team. We're more than happy to help you out with bringing this into your practice, building everything out. And if you have any ideas or questions or future webinar ideas, topics you want to cover, we're doing these things. I'd love to do them every month. We're typically doing them every quarter right now. Please share with us your suggestions. We will do our very best to bring those resources to this community. Keep an eye out for our newsletter. It is going to be coming out, I think it's this week. Tons of really fascinating articles in the PRP knee space, specifically looking at things like combination therapy. So keep an eye out for that when it does come. Enjoy your evening, everybody, and I'll stick around with Frank if anybody has any questions they want to fire away. Frank, we had one question here from Rodika. I think it shows a comment. Do you ever use cortisone response as a PRP criterion? Like my interpretation there is a diagnostic cortisone.
That is that's too bad we missed that one. I hope the person who asked is still on. Absolutely. So Connor, I've never seen any science on that. Have you seen any science on it? But what I say to patients is I say, look, I do this a ton with backs. Like I just did it the other day. Patient pointed to the top of his sacroiliac joint. And I said, let me stick a needle in it. If you say that's where the pain is, I'll put in some cortisone. And if that doesn't change anything, it's not your SI joint, it's a disc. It's a referred pain from a disc. And I do that sometimes with knees. Thanks, Patrick. Thanks for coming, buddy. I do that sometimes with knees where I say, if I can't modulate your pain or your WOMAC score with cortisone, I think like I'm talking like if it does nothing, like absolutely nothing at all, I don't think PRP is worth your money. I had a patient the other day who came back to me and said, you gave me PRP. She was happy. She was like, she was coming in for PRP again. So you gave me PRP 4 months ago. And I really want to do it again because it's natural and healthy. And the cortisone only helped for a week. So the clarifying factor there was the cortisone helped for a week. So we switched to PRP because she wanted it and we both thought it was reasonable. She said, I can't spend 3 months recovering from the injection again. I said, what are you talking about? She said, my knees were reasonably more sore for 3 months. And then I had a good month. I went, your knees were sore from the PRP I gave you for 3 months? She said, yes. I'm like, do you have other inflammatory stuff going on? She said, oh yeah, my whole life. Skin, hair, nails, bunch of inflammatory stuff, right? So that is an outlier. But that was a great example where the cortisone helped the patient for a week. And that was proof of concept to me that I can modulate her pain with PRP. And she was happy with it, just really unhappy with the inflammatory response she got.
Yeah, I don't know if there's any science necessarily for it, but I know that it's very common practice for the same reasons why you likely use it. If you know, it's just gaining accuracy in the diagnosis, and before somebody jumps in to spend, you know, 5, 6, 7, 800 euros on a PRP injection, making sure that you're in the right spot and that you're at least influencing the right structure. And cortisone seems like a economical way to do that.
Yeah. I think I do a lot more with hip joint and backs, right? Because there's so many referred pain patterns with hip joints or backs that are like, wait, I'm confused. I don't even know what's going on. I think there's more referred pain patterns with ankles than knees. Anyways, Noor asked me about PRP and HA. So in that video, I did a combo Durolane and PRP. I do that only when patients are super keen on it and they've had one or the other before. So to be clear, patient has to be keen, patient has to be not money sensitive. Usually that means they've got a good health spending account and or listed benefit for hyaluronic acid. The patient has already done the HA product independently and preferably also done the PRP independently. Now that's a lot of steps, but again, I think it's worthwhile going through it because if you get a person who wants to do PRP and HA and they're satisfied with it, it's like, excellent. Like, I love this stuff. This is great. Not only is it good for the bank account to help pay for your staff and the overhead and keep the lights on, but the patient's satisfied with it and getting a good outcome. And I'm convinced, I'm almost convinced that the two of them are better than either one on their own because the patient tells me, I've done each on their own, the combo is better. Then I'm like, great. I'm not going to get thrown under the bus by their physio. I'm not going to get thrown under the bus by their family doc or the surgeon because the patient tells me what the patient wants and they've had the opportunity. So that's my selection process, Noor. Anybody else have any other good selection processes? But essentially willingness to pay and willingness to conduct the science is my answer.
The only thing I'll add to that as well, because this just came up the other day, but last year when we started looking at the clinical evidence for combination therapy, there were 3 studies, and now there were many more clinicians that were adventuring into the space because of the perceived benefits of combination therapy, but the evidence didn't necessarily support it, or at least it wasn't very robust. Just last month, there were 3 studies on this specifically. So there have been a few more trickled out over the course of the year, but we're seeing the evidence catch up here. Take a look at the research roundup when it does come out. Read those studies. We're seeing more and more combination therapy in the clinical literature, and the benefits are there. The benefits are there. It's extending the life of the outcome scores much more than what you would get from either alone. So definitely keep an eye out for that and experiment with it. If, as Frank put it, you have a patient that's comfortable with the hyaluronic acid product that they're using, they've tried PRP in the past, they want to try to extend that benefit, they have the cost to cover it, I think it's a worthwhile experiment.
So Omar Khan asked a question about, wasn't that long ago we were seeing 5 billion platelets as target dose, now it's 10 billion. What's the extra bit you're going to get? I don't know, Omar. Honestly, it's a great question. We'd have to look at the literature on that, but then even more than that, you'd have to literally pick apart every patient. And I genuinely think there's so many of these papers that would be much more meaningful to me if I actually saw the handwritten or the electronically collected WOMAC scores or international knee scores of each individual patient, because I want to know what are the characteristics of the patients that are high responders. I don't care what the mean was. I don't care what the median was. Well, sorry, I do, but that's not the magic. I want to know which patients need the higher dose. And I think the answer is the older the patients you get, no matter what apart from elderly females with hypertension, you need fewer antihypertensives, but everybody else, the older you get, the more medicine you need. So I think the answer is the older your patient is, you probably need more platelets. I don't think the answer is the more severe the disease is, but I think the older their patients is, the more platelets they're going to get. The more platelets they need. The other thing is, if you routinely give a higher dose, I think you're going to get more responders than if you don't routinely give a higher dose. I don't know if I said that. Did I say that in a way that makes sense, Connor?
Yeah, and I think some of it is actually, Omar, it's the evolution of the way that we're looking at the treatment protocol in the studies. And so what you were seeing 5 years ago was similar to what the CHU study looked at, that we looked at earlier, where we're looking at a series of weekly injections. And at each injection, we were looking at typically concentrations of 4 or 5 times baseline being that critical range. And when we're delivering about 4 or 5 billion, 4 or 5 mils at that concentration, you're actually only delivering about 5 billion platelets plus or minus. And that's when people were hanging their hat on this 5x baseline. But when you actually look at the totality of the platelets delivered over 3 injections, you're actually at 15 billion platelets. And what people have started looking at is, well, early studies, instead of doing these 3 by 5 ml weekly injections, what if we just lump them all into one injection and we deliver 10 or 15 billion in one go? It's more clinically relevant for our patients. We don't have to bring them back. And that's where more of the recent studies that you're seeing are showing that, because one, systems have the ability to deliver that many platelets. One is kind of, we're solving that technical problem. And then B, it's more clinically relevant for people. And so it's just sort of moving more towards what's the total platelet dose, and how we're kind of just looking at the difference in just treatment schedules, right? 1 versus 3. I'll share.
Connie, you just described exactly the treatment progression with hyaluronic acid, right? Whereas Synvisc used to be a 2 mil plus a 2 mil plus a 2 mil, and then it went to 6 mils all in once.
Yeah, exactly. I'm going to, I just shared a quick image of sort of just a summary of a lot of different literature that looked at kind of the number of injections, but through the lens of what was the total platelets delivered. And a lot of these studies were from, 2020, 2021, kind of the same period where people were still looking at like 5x or 5 billion platelets. But just, again, looking at it through just what was the total platelet dose delivered, and can I deliver that in one injection? And if I can, am I seeing good outcomes? And that's what we are seeing. So really just a change in how we're reading the literature.
Olivia Caron, if he's still on, asked about a 2 times 80 ml kit. Connor, you should just do a 500 ml kit. So you can reach out to Olivier with that one.
Yeah, the 120, there isn't a 120. 160 is something that is going to be released to the market imminently. Yeah, 2 by 80 ml. I think that if we're looking at 10 billion platelets, that's what we're seeing is the standard. We're doing 80 ml in each knee if we want to get a minimum of 10 billion platelets. Frank, what are you typically drawing for each joint?
Minimum 60. Minimum 60, and then if the patient said they had a good response, I stay at 60. If not, I go to 90 or 120. Roxanne Labranche asked about nerve block for painful PRP. I don't routinely do nerve blocks. In fact, I almost never do nerve blocks for painful PRP injections. And there's a few reasons for that. One is it's an extra bit of procedure. It's an extra bit of medical legal risk. There was a paper in the Journal of Family Medicine about 10 years ago when I was doing some occupational walk-in injuries. And there was a doc, the paper was essentially a cautionary tale about doing unnecessary nerve blocks. And it was a story where a patient came in with a with a finger laceration. The emerge doc did a median nerve block because they felt they kind of wanted to do it for whatever reason. Patient had no problem at the time, but then about a week later developed severe pain and wound up with a lifelong complex regional pain syndrome. The judge found that essentially the emerge doc didn't practice the standard of care and did something that was unnecessary and that most doctors wouldn't have done. So that's just sort of a cautionary tale about that. Again, is that unusual? Yeah, that's highly unusual. Is that going to happen to you? No, of course not. But if it does, it's going to be life altering. You'll be like, shit, why did I ever think about doing those? The second thing is I don't like teaching them because I think nerve blocks require so much skill to do effectively. I'm really nervous that I'm going to enable somebody to do something that they don't have the ability to do safely in 100% of their patients. But anyway, that's my answer. But also further than that, I don't know if we have good data. Connor, do you have ever seen papers looking at is PRP more effective if it's painful or not painful? Because if I said to this guy yesterday, I had a retired CFL offensive lineman in my office yesterday, and I did PRP for his tennis elbow. And he had several PRPs done with his Achilles tendon a long time ago by a super famous Toronto sports medicine PRP doctor. And that doctor did not use any freezing in the kid's Achilles tendon at the time. But he did great. So he said, "Hey, do you do any freezing in the tennis elbow?" I said, "No, I think you can tolerate it without, and I actually think that pain is part of the therapeutic effect." He's like, "What?" I'm like, "Have you ever had a massage that like didn't hurt?" He said, "Yeah." "Did it do anything for you?" He's like, "Nope, they got to hurt to be good." um, Graston in the manual therapist office has to hurt to be good. Um, uh, Chris Bevington, one of my colleagues, ran the Boston Marathon in a killer time earlier this year. His running training has to hurt like hell, otherwise it's not going to have the desired effect. Connor, have you ever seen good papers about painful versus non-painful PRP?
No, I don't think it has to be painful. I think that and this is sort of anecdata, but a lot of the docs in the US that have kind of continued to dial up the dose higher and higher and higher and higher have kind of alluded to the higher the dose of platelets, the more biologically active they are when injected specifically into soft tissue. And so you get a more profound response. That response, if in part being inflammatory, you're going to see a little bit more pain associated with that. I don't think that's ever borne out in the studies. If you were to look at, zoom out and look at the adverse event rate for higher dosages of PRP, but I do think there's probably something to that. But listen, I think that there's ways that we can control pain for the patient. Whether that's being able to reduce the volume, that is a huge one that we've seen, moving from systems that they would give you 5 mils out and you would put as much into an epicondyle as you could until the patient taps out. You don't have to do that anymore. We can get that volume down while still delivering enough platelets to the patient. And then there's other things we can do too. If the anticoagulant is causing the product to be a little bit more acidic, we can buffer that with sodium bicarb. There are strategies that you can take to deal with the pain while not compromising the platelet dose. So if you have a patient that, again, I think that a little bit of pain isn't necessarily harmful. But if you're dealing with this routinely in your practice and you're wondering what can I do to help, reach out to us, reach out to anyone from MD Biologics. We can kind of help work you through what are some solutions that don't compromise the outcomes at the end of the day.
Absolutely. And I just the final bit on that, and then I should answer these questions a bit more succinctly, and we'll get through them. I'm the first one in every single PRP video. I show you how I use low dose anesthetic, 0.1% lidocaine, when necessary to control pain in patients, because there are some radiologists in our area who said, no, we don't use any PRP. And then they put 5 mils into a biceps tendon. Like I had a guy say, I literally couldn't get off the table for like an hour. I was stuck there. I was fainting. It was horrible. So I am actually definitely I'm sensitive to the patient's pain, but also I know if the patient's tolerating it okay, hey, sure, let's get through without watering down the PRP at all by putting too much in the tendon, and then without adding any extra risk with the nerve block. But anyway, I answered that question too long. Omar Khan used the same approach for SI joint complex and prolotherapy injections, where you sort of stick in the needle, is this the right spot, with cortisone, and then if they get a good response, then you do Prolo, and if they want more, then you do PRP. I love that, Omar. Omar says we should do post-hoc studies of super responders. Oh man, we need studies on the super responders. I've got my sense that the super responders are people that do combat sports and who work out for a living. Who are good dudes and good dudettes who work out for a living. The firefighters I treat, they're humble, hardworking, extremely personable, and by and large, they all do well with PRP, as opposed to track athletes. Like I'm a track athlete. I did decathlon. I did decathlon at the University of Windsor, right? Track athletes are notoriously sensitive to abnormal sensations in their muscles and tendons because they're sprinting at the highest speed, and they have to like have a finely attuned alarm system. And it just, in my mind, it doesn't translate well to being able to tolerate painful procedures well, or doing well with stuff like that. What are the logistics of getting blood volumes of 90 and 120 with the key PRP kits? Essentially, it just means you got to have two 60 ml syringes and be good with changing syringes, or have someone help you. Personally, Michael, what I do is I use ultrasound to draw blood. When my needle's going to be in somebody's arm for a while, I use so I palpate their vein, find a good vein. look at it with ultrasound so I can see it also. If I know the needle's going to be in there a while, I use 1% lidocaine with a 32 gauge needle, and I anesthetize just under the skin, then down to the vein, and then a little bit into the vein. Just make sure I've got all the way through the vein. By doing that, I can then place a 16 gauge needle essentially almost painlessly. I say to the patient, like I literally, 0.2 of lidocaine. I pass a 16 gauge needle into their vein. I'm watching with ultrasound to make sure I know where it is. And I say, did you feel that? They say, I didn't feel anything. And I draw like 60 mils. I get like somebody to compress a vein. I switch it out, draw another 60 mils, and I'm done in like 2 minutes. Whereas if you use the 21 gauge butterflies with 12 inches of tubing, there's so much resistance. It takes like 8 minutes to get those two things full. So that's my little trick. And I think that's it for questions. Yeah, we're coming up on time. Thanks so much, everybody. I'm gonna get out of this chair. I've been here for about 6 hours now. I'm gonna go on the treadmill and I'm gonna watch the second FIFA game today. I know it's already finished, but I'm gonna watch it and enjoy some soccer while we still got it. Thanks, everybody.
Good. Thank you, everyone. Thank you, Frank.